Good evening, everyone, and we commence this webinar today. So may I welcome Dr. Prashant Gupta to please introduce our speaker for the evening. Thank you, sir.
Yeah, thank you, Shama. It's a great pleasure. I introduce our distinguished speaker for tonight's webinar on AI in smear evaluation. Dr. Sonal Jain is a luminary in the field of healthcare and artificial intelligence, and her expertise is bound to enlighten us all. She is Director Hematology, Modern Diagnostic and Research Center, Advisor Hematology, Mahavir Cancer Sanstha Patna, and founder of Ashi Care. Dr. Jain has been at the forefront of leveraging AI to improve the accuracy, speed, and efficiency of smear evaluation techniques. Tonight, she will share her invaluable insight, research, and vision for the future of smear evaluation with AI. Please join me in welcoming her with warm virtual applause. Dr. Sonal Jain.
Thank you, Dr. Prashant. Thank you, Dr. Santosh, entire APP Haryana team, Varun, Mindray team, for the honor and privilege to share this experience. And without wasting much time, I'll start.
We were able to see your slide, ma'am. Now it is not.
Just give me a
visible.
second, ma'am.
Yeah.
Yes, can you see it now?
No.
Can you see it now?
Yes, it's visible now, ma'am. Thank you.
Yes. So sorry for the delay of a few seconds. So I'll be discussing about this much hyped kid on the block, which is very much around us now. Artificial intelligence in peripheral smear evaluation. So I'll begin with this. This is a snippet of a paper published in 2021, 2 years back, and where we were anticipating how artificial intelligence will disrupt diagnostics in this field, that is hematology. And here is in 2 years, it has there in every subspecialty of hematology, every diagnostics there. So I'll suggest everybody to go through this article where it discusses in every test that we do in hematology how AI plays a role there. In this particular presentation, we'll be discussing only about the cytomorphology, that is AI assisted peripheral smear reporting. So AI assisted peripheral smear reporting basically has two major steps. The first step is that manual microscopy, a glass slide which we are used to evaluating under microscope, becomes digitized and it converts into digital data with the help of slide scanners. And this digital data then by data-driven analytics, that is softwares, is further analyzed, which is the artificial intelligence. The slide scanners can be of varying specifications, manual and automated. And these slide scanners, which can be integrated into the microscope or separate scanners, their specifications are different from the ones used for histopathology and cytopathology. As we are all familiar that we don't evaluate smears in the same way as we evaluate histopathology sections and cytosmears. And this digitized smear is then followed by AI-driven analysis. In only a few slides, in very brief, I'll be giving you an overview of how this AI thing is done, followed by case-based discussion. So how does it do it? So there are AI models which detect monolayer of the samples from peripheral smears. At the outset, it looks like that peripheral smear is a monolayer, but actually it's a three-dimensional structure. So the then analyzed further to classify and sub-classify. So somewhat similar to that our eyes look at the cells, and that the data that our eyes have captured is processed by our brain. This data that is captured by that digital microscope is analyzed by that artificial brain, which is artificial intelligence or the neural network. A snippet of a brief, just an overview of how this workflow goes. So manual microscope is replaced by a slide scanner. This is replaced by slide scanner. The slide is then processed. Cells are located and images are captured. And these captured images, and instead of going to a human brain directly, it is first going into this artificial brain, that is the neural network, which is classifying these cells. And this is then re-verified by the human brain, which is review and verification process, which may or may not be associated with the remote review. So just like we have learned over time that this is a neutrophil, this is a lymphocyte, and these are the different cell types, this artificial brain or the neural network is also trained over time to see what different cells look like. And after this data set goes to that artificial brain or the neural network, it classifies and sub-classifies these cells. Similarly, for red cells, what we call as poikilocytes, different cell shapes of RBCs. This system also classifies these cells into various subcategories. So this is one of the windows that once the input, that is a slide and image, is given, the output that it gives to us on our screen is somewhat like this. So this is the summary of that AI analysis, and then it has these further sub-classifications. So it has already classified these images into WBCs, RBCs, platelets, and the subcategories. So the WBC category, these are the different classes in which it can characterize. So actually the number of classes any AI software can classify is variable across systems, across softwares. So this is one of those systems. So in one window, one can see all the neutrophils that it has captured from the smear. So the total cell count here it has counted is 100. It can be increased to any number of cells of user's choice. So in one particular window, you can see all of the neutrophils. You can review it, whether there is toxic granulation, there is hypersegmentation, there is pseudopelgal. So it is, instead of examining the whole smear, one window shows you all the neutrophils. Similarly, the lymphocytes, here you can pick up if there are any hairy cells, if there are downy cells, if there are any reactive lymphocytes, all can be seen and reviewed from here. The monocytes, eosinophils. So the important thing to understand is that although the AI has classified these cells into some category based on its intellect and learning, the reviewer has to review these and recharacterize anything which the system might have classified wrong. So it tells that there are 3 atypical cells, but I don't think these are atypical cells. I can reclassify them and put them into the correct categories. This window is there for each of these categories. So reclassification by the observer, by verifier is necessary. So this is the window for RBC. So from WBC move to the RBCs. It also characterizes into different cell types, and this goes on to teardrop cells, phagocytes, and all different kind of cells based upon the software that one is using. Or you can so this is the microscopic view. Why I put in here is that I personally find this window most useful for RBC classifications, because as you all know that categorization of the RBCs also depends on the part of the smear where RBCs are seen, and it is also susceptible to many artifacts. We all see kinase-created cells and stomatocytes and even artifactual target cells, etc. So this view enables RBC classification. So, I mean, this gives you a number, but our conventional learning tells us that anemia typing is done the way we are used to seeing it under the microscope. So this view is a whole slide view. So actually you can review it, the smear in each and every pick in this manner and actually scan the whole smear just like you scan the glass slide. So this is the platelet window. It is giving an estimate of the count based on the way it has been taught. And it also gives giant platelets and platelet counts. So here again, when it is giving these platelets, you can look at it. It might have counted some debris, some fungus, or some degenerated cells into platelets. You can click on each of these picks and recharacterize them into the right category. And after one has reviewed it, that is how the final final pick will window will look like. So this thing here you can put your add all your findings and give a final impression here. And this will get edited according to your re-verification or recategorization that you have done. So I'll take you through some of the cases that I've seen over past 2 years. So this is a 47-year-old male who was a resident of Gorakhpur, Uttar Pradesh, and his hemogram showed a severe pancytopenia. Now, this smear was prepared, and the doctor there saw some atypical cells. And since there were atypical cells and severe cytopenias, he wanted me to review this smear. And the AI analysis was like this. Since it was severe cytopenia, the AI model also could not count too many cells. You can see the rejected cells are these many, and total cell count is only 22. But it said that there are some 6 atypical cells. So these 6 atypical cells I could review in one window, and to my surprise, these were abnormal promyelocytes. And I was reviewing this at 10 p.m. in the night before going to bed, that some smears are there for review. Let's look at them. And this was an acute promyelocytic leukemia. And as we are all aware, acute promyelocytic leukemia, if diagnosed and treated in time, it is curable, but a delay in diagnosis can be really fatal for the patient. So this patient was immediately referred to a higher center for appropriate action. And in less than 24 hours from Gorakhpur, this patient shifts to Gurugram, gets diagnosed with a bone marrow confirmed on flow and molecular workup to be acute promyelocytic leukemia, and survives till date. Another patient, a middle-aged man with splenomegaly, again severe anemia, not so bad TLC, not so bad platelet count. But what do smears show? Have a relook at it. The TLC is not hugely deranged. Platelet is not too bad, but what does the smear show? Smear shows these blasts. Now, so although AI has a window of atypical cells and blasts, I would like you to see that these blasts are very heterogeneous. Some are small, some are big. So similar to a junior doctor, junior resident, for the AI also, it is not always possible to perfectly classify them, but it gives you an idea that at least the bigger, the most clear-cut blast, it will pick and tell you that have a word with, give you a word of caution that do see those images carefully. So you may have to recategorize them pick them up from the monocyte window, the lymphocyte window. But yes, an immediate review and a diagnosis is possible sitting far off from the place where the patient is. And in this group of patients, fast diagnosis is extremely important for survival. So smear had these blasts, so it was an acute leukemia. The source triaging could be done in time and patient could be treated. So some of the similar cases where an acute leukemia was picked up, which was enabled by the digital and remote review process, and a fast confirmed diagnosis could be given and patient could be treated in time. More of those cases. A 50-year-old male, severe anemia, severe thrombocytopenia, and indices are not so bad. But what do we see here? Normal to large red cells. And again, since I can review all the neutrophils in one window, it was difficult to miss out on the pseudopelvic neutrophils. If the same thing has to be done on the smear, it is very likely that, it will show me some 100 neutrophils in one window. So the review process becomes faster and chances of missing out on subtleties is reduces significantly. So this patient, which had elderly, not really elderly, but a 50-year-old male with severe anemia, severe thrombocytopenia, actually had a myelodysplastic syndrome. So again, MDS can only be suspected on a smear, but suspicion can be done only on a smear evaluation, and that smear evaluation, if assisted by AI, makes the review process more efficient. Another patient, not so bad hemogram, only a mild anemia is only abnormality, but she is 71 years old, and the pseudopelvic neutrophils I could see, and this RBCs are normal to macrocytic. The suspected MDS, so bone marrow, again a referral to a higher center where everything else can be done in time, could be initiated fast. A 53-year-old female, only problem she had was a severe anemia. And what do these smears show? She had rouleau, and she actually had a mild backache, which is common in females, especially elderly females. It's not a finding that is given too much importance. So she just had a mild back pain and a severe anemia, but a smear evaluation picked up a suspect plasma cell dysplasia. And again, timely referral, timely diagnosis. Smear cannot diagnose, but smear only can suspect. A bone marrow aspirate biopsy, definitive workup for multiple myeloma was done. Patient was diagnosed to have multiple myeloma. 42-year-old male, anemia, high TLC, cell counter DLC looks somewhat like this. But again, AI evaluated smear showed me there's something in the basophil window, something in the immature glans window, and it was not difficult to pick up a chronic myeloid leukemia. So suspect CML, and interestingly, this patient's smear was never evaluated before. This patient, his endoscopy was done. He had some vague GI complaints, TLC, high TLC, which was assumed to be a reactive secondary to his GI complaints, but a smear was never evaluated. A smear which is triaged by the AI makes the diagnosis faster. This patient had CML, which was confirmed by BCR-ABL testing, and definitive treatment was initiated in time. Elderly male, not so bad a CBC. So if this kind of a CBC comes to our lab, how much attention it will receive, I'm not sure. But this smear was made and it showed a monocytosis and a left shift and some dysplasia. Pseudopelvic neutrophils are here. So dysplasia, monocytosis, and with these counts, which are not very bad, but yes, they are not normal also. So this patient has a myelodysplastic syndrome, MPN overlap. So pseudopelga, very specific feature. And again, a review process is made more efficient because it is sorted out already for you. Very high TLC, a smear evaluation, a lymphocytosis with these smudge cells, and it was a CLPD. Again, lymphocytes in one window can be reviewed for morphology, whether this is a follicular lymphoma spillover or it is something else. So this morphology review becomes more efficient. Or it is, although the TLC in this case is very high, but it could have been lower TLC also, where you want to differentiate it from a reactive lymphocytosis and a smear triaging made by the artificial intelligence. So, this analysis is close to a year old, and these were the malignant disorders that we could pick up by a routine smear review. Just to reiterate that PS is a very powerful tool in diagnosing hematological disorders. But here, it made me think, this whole exercise made me think that actually we feel that every diagnosis can be made by just giving by just doing advanced tests. But which advanced test to do has to be sorted out by a smear evaluation. Now, CBC, essentially everybody on the planet gets a CBC done sometime in the life. But actually, are we picking up all the abnormalities, all the pre-malignant conditions there on the smear? And the cell counter on which it is done, gives a flag. It tells us that a smear needs to be evaluated. But what is happening to these flagged smears? We have to introspect and see. So the labs, the specialist, one reference laboratory generally prepares the smears and reviews them, or one or maybe multiple, but not all the places where the sample is collected, the smear is not reviewed there itself. Sample is transferred to the reference laboratory where specialist is located. Now, from our knowledge and experience, we know that a sample whose smear is made within 1 hour or 4 hours, or a smear which is prepared after 24 hours, are they the same? Will we be able to pick up acute promyelocytic leukemia cells, or rather, will we be able to pick up even the left shift so efficiently? So these are myelos, metas, and basophils. So, and sample which is flagged, the smear needs to be reviewed. Yes, it is reviewed, but it is reviewed after a time lag. So one is the delay, that even if you're picking up acute leukemias, it will be slightly delayed. Secondly, the sample integrity, which is leading to a misdiagnosis. This is about the malignancy. So sitting in our laboratories, wherever we are as pathologists, we would argue that these are not the major chunk of the practice that I see. But there's something more? The most common abnormality in a CBC is anemia. And this is the statistics of our last National Family Health Survey, that out of 1.4 billion population, a huge lot, at least 1/3 of the entire population has a low hemoglobin. And interestingly, these low hemoglobins are not even flagged by the cell counters. So, what are we doing for these anemias? So we are actually, in spite of all the anemia missions that we have been doing forever, the anemia statistics say that anemia problem has only increased from the last time. And this is not just India, it is the entire world. You can see all these pink regions have some degree of anemia, mild, moderate, or severe. So, first of all, do we really need to worry about anemia? Yes, we do. I tell you about a friend who just had a 10 hemoglobin, but she's a sports coach. She does gymming. She has a very active schedule, but she says that I go to the gym and I have a blackout and I can't teach my students on the field. Although 10 hemoglobin is not a problem, but for her it is about a job. Her job needs her to be very, very active, but her anemia is not letting her do that. So we shouldn't undermine a person who has to work for 12 to 14 hours. Having a normal HB is important, because that HB takes oxygen to every tissue of our body. If it doesn't get oxygen, his mental capacity is reduced. So it's not just vague talk. It is just happen. It does happen. Just if you talk to people around us, we would know that. So just take you through some of the anemia cases. So the standard microcytic hypochromic anemia, moderate anisopoikilocytosis, anybody can tell. this is possibly an iron deficiency anemia. So saying that it is an anemia microcytic hypochromic or saying that it is possibly an iron deficiency anemia does make a difference. And we'll come to what are the other ways where we can do, but can we really ignore this peripheral smear, which so another patient with microhypoanemia with targetemia, it is possibly either a hemoglobinopathy or a liver disease maybe. So the once more, it has macrocytes and also some hypochromic cells, but there are these hypersegmented neutrophils, which my AI-driven triage is showing me. So I am dealing with a megaloblastic anemia, and this specific features are so specific that you can actually write this patient has a possibly megaloblastic anemia, give a therapeutic trial, a test for vitamin B12 folate. But nothing other than a smear can tell you, yes, this is a hypersegmented neutrophil with the macrocytic anemia. Please give a folate trial or vitamin B12 folate trial. So another that still had some microhypo. This is a pure macrocytic anemia with these hypersegmented neutrophils. So again, we put this slide under the microscope, or we see it on a digital microscope. We need to see it to say that this is a megaloblastic anemia. Just this slide I've earlier shown also that elderly female with anemia. So this is also cause of anemia. And in normal anemia, no cell counter can tell you that this has pseudopelvic neutrophils. Only your eyes can tell you that these are pseudopelvic neutrophils. Another young lady, severe anemia, severe thrombocytopenia. Smear has spherocytes and polychromatophils. So she has autoimmune hemolytic anemia. Again, something which so specifically can be told by a smear only. Spherocytic anemia, do a Coombs test and a retic count, and you will have a diagnosis. And this is not uncommon. Trust me. In the last week, I had two patients, one with a CLPD, but smear. So that patient has a hemoglobin of 5, but a smear has not been seen and told that your mother has an autoimmune hemolytic anemia, which will be cured by some only immunosuppression. So, and another friend who's relative with a 3HB sitting in a remote village in Punjab, all the investigation, the roaming around that blood transfusions are being given, patient is not getting better, she needs to be rushed to a referral center. But actually, she only had an autoimmune hemolytic anemia, the treatment of which does not need to be at a referral center. Only a diagnosis that needs to be done at her village, which can change a whole lot of things about her life. Moving to a center, moving to a higher center, roaming around, leave with all the expenses of roaming around and everything else, and versus a well made diagnosis to everybody sitting anywhere is a huge difference for quality of life of everybody. So anemia diagnosis and typing, although it's not the most glamorous thing we as pathologists do, but we need to think that I feel this is an important reason to accept digitization. And it can have a huge public health impact. And again, these anemias are not something that is flagged by the counter. Some of those can be diagnosed well by histograms and everything, but there are a whole lot of features that only our eyes can see. Hemogram does tell us anemia, but doesn't flag it. But yes, we have a whole lot of cell counters now with advanced flagging options, advanced differential count options, and very accurately they do so. Advanced histogram options which can be analyzed to pick up different types of red cells, yes. And newer parameters that keep getting added every now and then, and there are a huge number of them. One needs to be apprised of them, yes. And they do enable specific diagnosis. But are they actually the complete answer is one? Some of the things which cell counters cannot give us. Even if they can give a flag around some of these, they can't tell you, yes, it is this. For that, again, you will have to see a smear. So, Hule, hypersegmentation, pseudopelga, lymphoma spill in a TLC of 14,000 or 12,000 for that matter, that you can pick up only if you review those lymphocytes and say this percent of cells are not normal. Cystocyte, a white cell, a G6PD deficiency. A G6PD deficiency is not uncommon. We have seen patients with hemoglobin dropped from only 14 to only 11, but the smear was full of white cells. And I'm looking back, asking the patient, come to know that he has a skin disease and started taking Dapsone. And a patient of leukemia, you can see the blast, but for all you will have to see the smear. So all of these things, smear evaluation cannot be disputed. And the high-end counters, yes, they have a lot of options, but can everybody afford these kind of cell counters? So if we look at the 1.4 billion population of India, everybody has access to CBCs. And which are the most common cell counters? We really need to see what is the capacity of the most commonly used cell counters? Can they diagnose these very type of disorders? Alone, possibly they can't, but with the smear evaluation, they can. So I just say that that humble peripheral smear in the entire limelight of everything, the entire gamut of diagnostics that we have today is somewhere forgotten and orphaned. And I mean, we, the next generation, I don't know how much. So basic, so accessible to all is what? A basic cell counter and making a smear from a single drop of blood. But what about, so you can see that smear by simply a microscope. If you have low vol, you have adequate commitment and adequate number of people for the workload you have, just see that slide under the microscope and that's enough. You feel, but if you feel that I want my pathologist is not available after X amount of time, so those hemograms that are coming after that time, they have to be released for the constraint of TAT, etc. You can digitize that microscope, that slide, and review it from anywhere. So one really does not have to not see any flagged smears in that case, and one does not have to not see the anemia. So review of all the required smears become possible if you digitize your microscopy. Third possibility, depending upon the workload, depending upon the commercials, you can have a digital microscopy which is enabled with AI. So what does any AI help is? It decreases the review time. It is doing the triaging for you, just like any one junior. When you have huge workload, you want the junior to sort the slides for you. Yes, that junior will not complain that, sir, I have 100 slides, I can't review all of them. If he only has to review the flagged smears, or he not give less time to the non-flagged ones, etc. It decreases review time, and again it makes possible to review all the required smears. So we over time have possibly reduced this practice of smear evaluation for various reasons. Or I wouldn't miss my words in saying that most of us would inside agree that smears are not getting the adequate amount of attention because it's supposedly labor intensive. This AI can be a helper. If we are seeing 10 smears today, it enables us to review maybe 100 smears. So if you have a digital with AI with a remote review, then if you have two atypical cells in a smear and you feel, I don't know, if they are, instead of just letting it go, कि छोड़ देते हैं, 2 cells है, you can show it to a friend, show it to a colleague, and that's it. So it allows networking like never before. So it allows diagnosis like never before. The rarest of diagnosis will come to a pathologist. We don't have to let it go. Anything which we feel is not something I have not seen, we can review it, get it reviewed with anybody in the world we know. So this AI, digitization and AI, it enables more efficient and more accurate reporting system. So this has been highlighted in in the Lancet, this issue of 2018. It has back-to-back 3 papers which have tried to address that pathology and lab medicine service in middle income and low income countries. So they have highlighted that healthcare cannot be improved without an efficient pathology and lab medicine service. And it is tried to address this problem, that every nook and corner of these countries wouldn't have access to the best laboratories. So, but how can one bring that laboratory to that underprivileged part of the country or the world? By digitizing, by the technology. Because just given, I would suggest that to Google this issue, and it's free of cost available on net. And it has highlighted through a series of cases that how digital networking can empower the doctor sitting anywhere and can take the best healthcare to anyone sitting anywhere without adding additional cost. So it highlights the need of telepathology services to be networked in a manner, uh, in a tiered kind of a network, so that one pyramid kind of a model where the apex of the system is able to cater to the needs of everybody at the bottom of the pyramid. So it has many case scenarios, out of which one I have just highlighted, that what is trying to say. Just trying to say that the remotest center would have the basic testing facility. But that basic testing facility, the doctors there can diagnose some bit of those cases. Whatever they cannot diagnose, they can just share that data with somebody at the next level, and somebody at the next level can guide them that what special test they need to do. And somewhere in the pyramid there would be a specialist sitting there who would clinch that diagnosis, and the patient who is sitting in that village without even shifting to that to Manhattan or anywhere will get the best treatment. And so there's a corollary in this paper. They have highlighted a patient who went to a primary care center, was suspected to have a specific renal disorder. The mother was told, you go to the medical college. The mother said, I will have to leave my job. I can't afford, and that kid dies. So specialist doctors are skewed in favor of metropolitan cities. And again, a reiteration of what, so the samples are tested, but they're transported to the reference laboratory. So the way of working somewhere isn't able to deliver what it is supposed to deliver. And a very important point that hinders us, and it's a question that we keep asking and possibly not giving this kid room for working. I mean, it's maybe a may or may not be interest, but I thought I would like to address it. So this smear, which is digitized and which has this AI, which has learned something which we were supposed to know forever, can AI do it all on its own? So I'll also take you through some of the pictures, which in my last presentation also I've highlighted, but just reiteration that this is something that this told me it's an atypical cell of blast, but there's no nucleus here. This is not a blast. This is a cabling in a patient of megaloblastic anemia, and since this PG with the junior pathologist, that which is the AI, has not seen it, it put it anywhere. So it does not say I do not know. So this has the pseudopelga neutrophil, which since there were two pseudopelga, it looked like one nucleus, and the cytoplasm was agranular. It mistook it, instead of a neutrophil, it called it an NRBC because it was a hypogranular neutrophil, hypogranular and hypolobated neutrophil. So again, this called these as atypical cells, but lot of them are just monocytes, and a few of them are just reactive lymphocytes. So a re-review and a recategorization is necessary, but yes, it does triage it. Reviewing this 59 monocytes won't take 2 or 3 minutes. It can be done in fractions of seconds. Similarly, reviewing these 113 IGs won't take long, although they are just 5%. If we do 100 cell count and we are seeing 500 cells, then also we won't be seeing these 113 immature granulocytes in a manual microscopy. So sorting and triaging is something which it does beautifully, and we as humans are technically limited in doing that. Because even if you see this smear, this has analyzed some 2000 odd cells, and the number of cells it will show me here would be enormous. Missing out on anything becomes impossible. Again, another limitation or artifact that I'm showing you, this calls these as microcytes. Now, do you see any microcytes? These are smaller cells, but they are non-hemoglobinated. So these shouldn't be classified as microcytes. It does just knows that microcyte is a smaller cell, but a smaller cell can be a spherocyte also. That's what it is over here. So a manual review is necessary. So just another thing, nuclei which do not have a cell membrane because it is degenerated, it is counting as a platelet count. It sees these as platelets sticking together. These are giant platelet is called, but these are again nuclei for neutrophils. But how do we know? To us also, these are just 3 blobs of stain, but we know from our experience that these are not blobs of stain, these are nuclei. So the way forward, we should use AI tools to help us in making diagnosis in a better manner and making more diagnosis. And it helps us in better management of our time, the most, which to my mind is the most precious asset which each one of us have. If you can review a most important CBC or smear at 12 o'clock in the night without being there entire day and still picking up leukemias, still picking up XYZ things, still picking up dengues, which it does show beautifully. I just missed on putting some of those slides here. So the quality of our life also becomes better. At the same time, we are able to deliver better. So AI is actually a tool in our hands which can empower the entire mankind. Just a summary, some of this I've said in previous presentations also. Just one thing that I would like to highlight is that medical deserts can be removed only by using technology in its best form. And with enabled digital and AI tools, it is possible to achieve healthcare for all, equitable healthcare for all. One does not have to, for the people who are staying in remotest parts, it is most of the time not possible to fly to Delhi or any other second tier city for a diagnosis, which could be, which is, it is, over time, it is possible to make that diagnosis there and tell them whether you really have to fly or you can be treated there. And it enables us to be the blueprint of the best human intellect. Now, I am a hematopathologist. I cannot do neuropathology. I cannot do nephropathology. The best people can build up AI tools, then it will continue to serve the mankind till eternity. So, and not just AI tools, the digital tools, the various of the diagnosis can be made within minutes instead of possibly never being made, or if being made, they would be many times delayed to the extent that patient can't be salvaged. And this enables us to serve till eternity and serve all. Thank you, APP Haryana team. Thank you, Mindray, and thank you to the team because of which I've been able to do this with Dr. Rahul Baga, DigiBridge team. And thank you.
Thanks a lot, Dr. Sonal, and it was very enlightening. Actually, there are a few questions which I'll ask. Is the scanner for, by Manoj Kahar, is the scanner for hematology smear compatible with use of oil immersion lens, or it just takes pics and magnifies on its own?
So, Dr. Manoj, there are various types of scanners. Both types are there. Some which do use a 40x or 60x and do a digital zoom, others which scan under an oil immersion. So, both kinds of scanners are there.
Okay. And how reliable is AI to differentiate myeloblast from lymphoblast?
Manoj, I guess I've addressed this, that I would say AI, the learning of AI is not complete. And to my mind, it can never be complete because heterogeneity is so much. So I've shown you the leukemia cases, and trust me that actually giving an accurate differential count took me close to an hour, because smaller blasts could be lying with lymphocytes, bigger blasts could be lying with monocytes. So there could be AI softwares that are available, which can differentiate, but this differentiation to even human eyes cannot do. We as morphologists do not write myeloblast and lymphoblast. We just say blast and do a flow cytometry to say it is a myelo or lymphoblast. The only specific feature to a myeloblast is an organ. So now in morphology, we do not call anything as a myeloblast or leukoblast.
Are there similar AI tools for bone marrow analysis?
They are being developed. They are being developed.
Okay. And Dr. Devki is asking about the infrastructure and cost of it.
So, ma'am, I think the industry people should be addressing this, and I can only say that infrastructure cost, at the speed at which it has reduced, is phenomenal, and in times to come, it will be much less, and people are developing handheld cameras and developing AI tools based on that. That is, they are doing annotation on this. That's underway right now. So the cost, you can imagine that right now, whatever cost I say wouldn't be the same in another year to come, not longer, I would say. It's right now also affordable. In 3 years, it will be even more affordable. Because that's the only way it can survive. Because its power is its reach, and it cannot reach if it does, the cost doesn't reduce.
But still, I think the cost is very high, and it's not affordable for the common people. And I hope that with passing time, it becomes affordable to everyone so that it can reach the rural area where it is needed.
So we'll take this off the thing. When the speed at which it is reducing is more than I expected, actually. 2 years I'm losing this, and when I began, and today it's the fall is dramatic.
Okay. Yeah. And your presentation was very lucid and very nice, and with so many pics. I think any other question? Anybody else? 2 more questions have come up.
So yeah, this 100 of those they have these AI tools which can pick up malaria parasite. Yes, they're there.
And how good is the AI in detecting malaria?
So there are AI tools which can pick up malaria now. There are.
Yeah. And what is the latest development in lab testing of iron deficiency anemia by way of artificial intelligence?
So by way of artificial, this mere evaluation itself by AI tools is very new. So the focus is on the biggest cell, has so far been on biggest cells, that is the WBCs. So the AI on smear, I would like to talk about my experience. Right now, I would say that they are picking up anemias by AI tools hasn't caught much attention so far, because it's not that easy. Also, I mean, it will take some time to develop. It could require concentrated effort, because anemia is not perceived to be glamorous in first place.
Mm-hmm. Actually, what I feel is that at one center, the scanner should be there, the slide should be stained and put in the scanner, and the scanner will take up all the images and will send it to you, and you will review the slide and the pictures, and then you give your diagnosis, right? So one person is asking, is there any free versions available? I think the scanner itself is the cost which is involved in this AI process.
Yes. Yes.
So
Right.
anybody else?
So Dr. Arvind Kumar, LD bodies detected by AI, LD bodies are picked up on bone marrow. So right now AI for bone marrow itself is underway. So LD bodies right now, to my knowledge, hasn't been developed. So malaria parasite, since it is picked up on the smears and is much more common, it has been developed. LD bodies is not a common problem. So I mean, whatever is built first is the one for which the demand is likely to be there. The cost per se is a constraint. So having an LD body AI would have no bias, frankly. Right now.
Anything else, Varun? Varun, Nikhil? Anything else we can do? So as we draw the...
So if we have our product manager hematology who takes care all these instruments. So we have a short presentation from him for the digital morphology instrument that Mindray has. So I will invite Mr. Amit Casey.
Yeah.
To give us a short presentation of MC80. So Amit, you can share your screen now.
Yeah. It's visible. Shama is visible.
Yeah,
no, not yet. Amit,
coming up.
not yet.
Not yet. Should
Now?
be coming up now.
No,
Amit.
Amit, it's not visible.
Once you share the screen, you have to choose the window, I believe.
Yeah.
That's where the gap is.
You can click on the share screen button.
Yeah, I already shared. Click on share screen. Now?
No.
Just hold on. I think now it's shared.
Yeah. Yes.
Yeah.
Okay, good evening, everyone. My name is Amit. I'm here as a product manager for hematology. First, I would like to thanks on behalf of Mindray, thanks Dr. Prashant and Dr. Sonal and APY team to joining us and giving us opportunity. So today I'm going to discuss about our digital morphology, cell morphology analyzer. So this is a MC80. It's a digital morphology analyzer. So here, as you know, Dr. Sonal already explained that there are lots of challenges when we go for the microscopy, where we have to adjust the microscopy 10x, 40x, 100x, and dripping of oil and dozen of focus we have to do on that during the microscopy, and it always differ our tests. So for that, we have a better solution. So how can we maintain our TED? I will explain you in a further slide. So this is our proper platform. You know that Mindray is a very innovative company. We always believe in innovation, and basically they make an instrument where we can give you the proper solution, state-of-art instrument. So it's an instrument where we call combination of cell counter, ESR, slide maker stainer with slide digital morphology. So the motive of the instrument that we can save your manpower as well as the risk of missing tests, human error, and we can say that the TAT, improving of the TAT. So this is a different picture of digital morphology. So first, this is a slide maker stainer. When sample come from the cell counter, it goes to the slide maker stainer according to the decision rule and according to the different panels. So it goes to the slide stainer and maker. Then after that, automatically it goes to the slide digital morphology. Digital morphology will do the morphology of the cell and it will send to you the validation screen. And you can see all data and all cell morphology in validation screen. And there is other option also. If you have a separate slide, single slide, so you can put it in this area, and the cell counter, this digital morphology will take and do the DGLC on that area also. So as Dr. Sonal told that it's totally depend on the workload, how the infrastructure, as question has come that what is the infrastructure should be there. So totally it's depend on the workload. So like example, if you're having a workload of 500 sample tubes per day of hematology, so then go for the CL 600. And if you have a more than 500 sample per day, then you can go Cal 8,000. So basically the hematology has the solution is that we have a hematology analyzer as well as slide maker stainer, morphology. So total hematology lab solution we have. So now what technology we use in our digital morphology? It's a three-dimensional technology basically, and we call depth fusion technology. This depth fusion technology can go over 20 depth of field. 20 depth means it goes like a 3 dimensions. It take a picture of every cell like a 3 dimension and give you information of loblarity, granularity, nucleocytoplasmic ratio, complexity. Each and everything is noted by this fusion technology. So now we have a library where we take all AI data, and lakhs of AI data is available in there, and it is authenticated by the remnants of professor and directors. So this is the library we have, and though all cell are compare with morphology with your present morphology and which slides you review in the digital morphology. So it compare with it with thousands of lakhs of cell and then give you the results. So the benefit of this technology and the slide review, that when we go for the slide CBC model, when we do the CBC, automatically it gives a signal to the slide maker trainers and the slide digital morphology. The slide maker digital morphology will get the signal that there is some abnormality present and it has to take a corrective action. So what are those corrective and morphology action it takes automatically? So if any kind of blast cells reported by the cell counter, automatically the digital morphology will do multiple WBC scanning, means double, multiply the double. Example, we used to do like 100 cell, average of 100 cells, 800 cells. It automatically converts to 1600 cells in the same time. It will not take much time for that. For anemia, it will go for the RBC, different morphology, like anisocytes, microcytes, different morphology. Try to review on that condition. Low platelet count. If the low platelets are there, so we have a platelet pro technology, which actually the microscope focus on tail and edges to diagnose the aggregates. Aggregates are there or not. At the same time, I will show you in the further slide. And other thing that you can customize your rules, so automatically it will go for the scanning and slide making. So now one of the example that one of the patient having a WBC count, high WBC count with IG and mature granulocyte with blast cells. So automatically this cell counter will give you the signal to the digital morphology and automatically double the numbers. And when it double the numbers, try to find out those abnormal cells. And when it get any kind of abnormal cell, it will give you the proper picture of those cells. Now coming to the next case study, when the platelets having a lower side, when any kind of patient having a low platelet with review flag. So what it do, it trigger platelet automation triggered automatically. So it's a platelets basically, it's to microscopy focus on tail of the slide as well as the edges of the slide. So now coming to the next slide, that when we go for differential leukocyte count and any kind of aggregates come in the digital morphology, it also start to do more platelet pro automatically. So what is platelet pro is, as I told you, it's basically count the edges as well as the tail of the WBC. So these are the actual method we used to do in manual microscopy. In manual microscopy, we focus in this area, and it takes too much time, and we have to focus each and every time where the slides are there, and we need fine tuning. It takes too much time to do fine tuning to focus the cell. So nowadays, actually what we are doing, we are focusing on tail of the slide as well as edge of the slide. So now how it's do. So when if the machine gets a signal of platelets clumps, platelets pro started working automatically. And how it works, it goes to the tail of the cell, and you can see the speed. The high speed scanning starts within 60 seconds. It gives you the result that platelets aggregates are there or not. So it helps you a lot to diagnose of aggregation of the platelets, which other competitor don't have. So now, as I told that some of the doctor asked that how we do with the satellite labs and how we'll get the data. So if you have a different satellite labs, different laboratory, we have a lab expert. It give you the information to your central lab so that you will get all information data in your PC, single screen PC, iPad or laptop, so that you can validate and you can see the cell morphology, the single building, single area. So now nowadays, the older instrument, what we have to do digital morphology separately. Then you have to take care of LIS. You have to take care of cell counter software also. So combination of three create confusion. So what we have done, we have made all things in a single screen. In single screen, you can see all data at the same time. An easy way. Like with this particular patient, what is a DLC, what is a ESR, what is a other parameters here. Another thing also, you can take a printout of morphology on the report also. You can, if you want to share with your pathologist or any physician and any hematologist, you can share with the picture also. So thank you. That's all from my side. Questions, if any question, please, we like to answer. Shama, which you are with me, and all media teams are here to answer the questions. Thank you.
Amit, I would like to ask the cost of the instrument.
So Varun is with us. Varun, can you help us?
Hello.
Yeah, yeah, Varun.
Yeah. So actually, the cost of equipment in terms of hardware is not something which we can discuss right now. But
Yeah.
when we are given with a workload of number of samples a day, we can definitely work out a solution wherein it becomes workable. Because as we know already, the digital morphology and slide maker, slide scanner both do not have much consumable. So once they don't have consumable, they go on outright purchase and cost goes high. So the cost of the equipment and workable solution can be discussed case on case basis.
Okay.
Yeah.
And I find that the instrument is quite compact and it can
Yes, sir.
review single slide also. That is also very amazing.
Yeah.
And,
So not
and,
only the peripheral blood, even this instrument can review your body fluids smears,
yeah,
bone marrow smears, and whenever pre-classification is not possible because of any region due to any abnormality, this can also give you the digital images which can be post-classified upon review.
okay.
Yeah.
There are some participants who have raised hands, so I will allow them to talk.
Yeah.
So you can talk now and ask your question. You can unmute yourself and ask your question.
Okay, hello. Can you hear me?
Yes, we
Yes,
can hear
sir.
you.
Okay, my name is Obina, calling from Nigeria. So I wanted to find out, I heard the presenter mention that and that's a beautiful presentation, by the way. I wanted to ask how sensitive it is, especially for the detection of malaria, and how it is able to quantify between the species, the different species of malaria. Is it able to distinguish species, and then is it able to give information on the parasite density? Yeah, thank you. That's my question.
Yeah, so Viju, can
Shama,
you?
can I
Yeah,
answer that, Shama? Shama
yeah,
can answer
Viju
that?
or Varun can answer it
Okay.
because
So
we
I'll answer
recently have
that.
a paper published on it.
Okay, I'll answer that. So whenever MCAT is being used, it is always being used in the combination of our hematology analyzer, either 6800 or 6200 plus, who are equipped to flag malarial parasite, presence of malarial parasite in themselves. However, when the same sample comes to MCAT, which is digital morphology analyzer, that analyzer can flag a presence of malarial parasite. At the same time, differentiating between different parasite species like Plasmodium falciparum or vivax, that has to be done manually, because many a times the difference between their different stages is so minimal that at this stage in time, artificial intelligence or the digital morphology is not equipped to differentiate between them. So at this point in time, it has to be done manually. Maybe going forward or maybe some time ahead, we will be having some software which can differentiate between these species.
So Varun,
Okay,
I would
so
like to
is it
add
able
one more
to give?
thing. I would like to add one more point to that. So that recently we have upgraded with the detection of for the malarial parasite, and we are also coming up with that additional that upgrade which can distinguish between the vivax as well as falciparum. The first version has been released, and the second version will be, we are expecting in a month or four, that maybe in the Q2 of next year.
That's amazing. Great.
Yeah, you can continue.
Okay, yeah, thank you. So I was going to ask, what is the sensitivity that it has, as in what's the detection limit? Because, for instance, when in our system here, we combine microscopy and RDT, and we know that there's a threshold below which the RDTs will not peak, will not be sensitive. So I wanted to know what is the sensitivity of the AI in detection of malaria. Sorry, I'm mentioning malaria because I'm in Africa and it's endemic here. Thank you.
Sensitivity, as per our, we have done some two studies. Okay, not with this digital morphology, with respect to our instrument in combination with digital morphology, and we found that we have a sensitivity of 94%. Okay, we have not quantified till now. In quantification, we have not come up. Do you mean the quantification?
So we also have a paper published on BC 6800 plus, where we have given the sensitivities both for FALSI and Vivax. So and it's published in India. So we do have some studies on that also, but it's not on AI, it's on our hematology analyzer. So any further questions?
No, none from me. Thank you.
Okay, thank you. So Dr. Prashant, should we go ahead with the closing remarks?
Yes, ma'am.
Okay, so thank you everyone for joining in this webinar. And thank you, Dr. Sonal, for such an enlightening talk for utility of artificial intelligence in hematology. And it has really helped everyone to know what artificial intelligence can do in hematology and how you can it can never replace human eye and human brain, but it can be of a lot of help in our daily routine, where we have so much to do. Or like in a lab, we work, even if we work 24/7, it's less. But in such a heavy duty routine, AI helps us a lot. So thank you so much, Dr. Sonal. Thank you, Dr. Prashant, for being a mentor for every one of us and being the main person to initiate this webinar. I would also like to thank my team, especially Varun and Amit and Biju to be here. So we have two product managers, that's Amit and Biju, and Varun takes care of sales. So thank you so much for initiating this webinar. And we end this evening with this a thank you note. Thank you so much.
Thank you,
Thank
Shama.
you.
Thank you, Shama. It was very nice to have you as our coordinator for the sessions, all the webinars. And I hope we have another webinar on 7th of October by Dr. Rajan Verma. And he will be speaking on the pathologist perspective of the disease. So let's hope for the best. And happy learning.
Thank you.
Thank you, Dr. Prashant sir. Thank you, Dr.
We
Sonal ma'am.
await everybody's
everyone.
presence on 7th October too. So please be aware that we have another webinar series. This series continues with a webinar again on 7th of October.
Yeah.
Thank you. Thank you, everyone.
Thank you, sir. Thank you, madam.
Yes, Dr. Sonal, you wanted
Bye,
to
everyone. Bye. Bye. Take care.
Yes, thank you. Thank you.
Yeah. Thank you, ma'am. Thank you.
Thank you. Thank you.